abnormalities. So it's better not to look. But it does take some practice to be able to do good thyroid exams, and people do miss things. So you should do them frequently.
Okay.
Make sure you're doing them sitting up. I see in the hospital, a lot of times the residents will be examining the patient when they're laying flat in the bed. And it's very hard to examine the thyroid when a patient is laying flat, because it does fall kind of down and back. So you really can't feel the lower poles of the thyroid, and you can be missing relatively large nodules when the patient is laying down. So you really do need them sitting up. Make sure they swallow, because the thyroid goes up and down when you swallow, right. So that you can really feel the lower poles at that point, which could have a nodule there. So yeah, it does. We do need to be examining them, but the current thought process is less is better with the ultrasounds.
Okay. Well, let me ask you, obviously, in the middle of all this, you've been talking about hypothyroidism rather than Hashimoto's or other issues. And hypothyroid tends to be a very common problem. Why don't you give us an update on what you think is important for the listeners or for the teachers and physicians in the audience about your approach to hypothyroidism?
So when you have a hypothyroid patient, you need to make sure that the thyroid levels stay normal. If it's someone that you've had for a long time, you know they have hypothyroidism. It's just a matter of monitoring those levels and being aware of the doses that they're taking and keeping them normal. What we do see, though, from the onset is if you have someone that's a newly diagnosed hypothyroid patient, it's important to figure out, are they really hypothyroid? And I think that's one of the biggest mistakes that we see. And we're probably going to end up with a lot of this right now in our COVID universe here, because what happens is the phenomenon of euthyroid sick. And when people have illnesses, and particularly something like COVID that gets people quite ill, even those that don't end up in the hospital, that are just home with kind of the bad flu-like symptoms. We see this after the flu every year as well. So if someone is usually sick enough to be home from work, it's enough to cause euthyroid sick. So what happens is initially the thyroid levels go down a bit. And as the patient recovers from whatever the illness was, then the thyroid will respond with an increase in TSH to get those levels back up. The levels go down because of all of the cytokines and the inflammatory responses that happen from whatever the illness was. So as I was saying with COVID, obviously we have this whole cytokine storm. We have a lot of this inflammatory stuff going on. So the body realizes that if you have other things that are causing rapid metabolism, fevers, tachycardia, that you don't need all that T3 and T4 around. So the levels go down and you start making much higher levels of reverse T3. So when that happens, eventually those cytokines will fall. And then the pituitary realizes that, my levels are low, and that TSH transiently goes up. And it can go up out of the normal range. It's usually not that high. It usually is just above the top of normal. So most assays currently run 0.4 to 4. So it'll be 6, 8, something like that. So just a little bit above normal. But if you happen to catch the patient in that time frame, you will think the patient has mild hypothyroidism. And frequently, these patients end up getting started on thyroid hormone when they really didn't need it. And if you had just waited a few weeks, it'll go away. So whenever you're seeing these relatively modest elevations in a TSH that are less than 10, you really need to be talking to the patient about what's been going on in the last couple of months of life. Were you sick? Did you have any problems? What was going on? And if there's any question that they had some illness or that TSH is sitting less than 10, don't do anything. Just wait another 4 to 6 weeks and repeat it. Because if it was euthyroid sick, it's going to go away. And then the patient doesn't get put on thyroid hormone that then they get stuck on for life. And we all have these people in clinic because there's people that are on 25 to 50 micrograms of levothyroxine, and they've been on that same dose for the last 10 years. That's not Hashimoto's. Hashimoto's will eventually destroy the bulk of that gland, and the patient is going to be on an appropriate weight-based dose, which should be somewhere around 1.6 times their weight in kilograms. So unless you weigh 80 pounds, you're not going to be on 50 micrograms of thyroid hormone for life. So those patients more than likely got started when they were in a euthyroid sick phase, and then the thyroid will compensate. So if you give 25 to 50 micrograms, the thyroid will go, well, thank you, I won't make so much. And, it will downregulate the amount that it makes so that you stay euthyroid. But it would be fine if you weren't on the medication. But if you have them on it, you need to taper it relatively slowly so that the thyroid has a chance to work. And what I tell them to do is, they've probably been on this for years, so there's no urgency. They can just not take it one day a week. And a couple of weeks later, take out another day a week, and then another day a week. And, eventually over a couple of months, they've just dropped out all the days of the week. And then the thyroid can, each week start making a little bit more. So that's the first caveat with hypothyroidism is don't treat it if it's not real. So make sure it's not euthyroid sick. And then, once you start them on a medication, then you need to choose your patients with if they can afford the brand name thyroid hormone, it would be good. There's less variation in that. Mm-hmm. We see a lot of fluctuation in our generic doses, so that you have a patient on what looks like a good dose and their TSH is in the normal range and everybody's happy. And the next time you check it, it's too high or too low, and nothing changed. So we see this frequently with the brands, that the quality control that the FDA allows with the brands is much better than with the generics. So if the patient can afford a brand name thyroid, it's a good thing. As far as I'm aware, it's the only medication that the FDA does not have the same quality controls on it. So everything else, I would, tell people, please send people the generics because it's so much cheaper for them. But in this case, I would say use the brand if you can. Yeah. If the patients can't afford that brand, which, it gets pricey to do these brand name meds if the insurance won't cover them, then write on the prescription, please fill with the same generic company each fill, so that they're not, when you go to a pharmacy, they get whatever's cheapest for them. So one fill, they may have one brand of a generic, because, it's not really a brand, but one company of a generic. And the next time the patient goes, they get a different company's generic. And so it causes a lot of fluctuation in the thyroid levels, and the patient doesn't feel that well. So try to keep consistent with that dose. It takes 6 weeks to get to a steady state. So if you change a dose, wait 6 weeks, check the level again. If it's not in the appropriate range, then you can, modify it. But then you've got to wait another 6 weeks to recheck those levels. Once in a while, we find patients, even though there's a lot of different doses out there, they fall between two doses. So you put them on one and then it's too much. So you put them on the next one that's below it, it's too little. You can do things like we do with Coumadin, and it has a 7-day half-life. So it has one of the longest half-lives of any med we give. So you can give them 6.5 tablets for the week. So one day a week, they take a half a tablet instead of a whole tablet. And you can end up with a dose in between two doses that the companies provide. So that's a little, tidbit for people out there that are monkeying with the dose and they just can't seem to get it quite right. And the other thing is find out if the patient's eating with it, because it does not absorb at all if there's food in the stomach. So those directions about you have to wait 30 to 60 minutes for anything, including your cup of coffee, is real. So they need to be consistent about taking it fasting with no meds, nothing but water, and wait at least 30 minutes.
That's important.
So that'll keep those doses better.
Let me move on to what patients not always, but many are discussing: synthetic thyroid hormones versus natural products, doctor. Where do we stand with that these days?
Well, if you ask any endocrinologist, the natural products are not natural. They're actually ground up pig thyroid, so they come from pork, and they take a pig thyroid and grind it up, desiccate it, and lyophilize it into a powder. The problem is that animal thyroids have much more T3 in them than what we use. So the naturopaths and the patients love them. They think they're wonderful because when you take it, you're getting a big dose of liothyronine, the T3, which is the active form of the hormone. So it's like drinking a Jolt Cola every morning. And people are like, oh, I feel great. And they're all revved up. And isn't this wonderful? And this is a great thing. But the problem is that it runs those T3 levels much too high. And when that happens, you're running the risk of having atrial fibrillation, as well as most people that have thyroid hormone that need thyroid hormone, most of the time are a little older. And the problem is a lot of them are women. Thyroid disease and all autoimmune diseases are more common in women. And they may have osteopenia or at risk for osteopenia or already have osteoporosis. And when you make them hyperthyroid, you're getting a lot more bone loss. So it's not a good thing to do to have those natural hormones, even though, people feel good. It's kind of like the whole steroid thing. People always feel great on steroids.
Yeah.
But, there's obviously lots of downsides to steroids. It's the same thing when you're taking these natural hormones. The other thing is if you have a young woman who's using these natural hormones, T3 does not cross the placenta. And if you have a hypothyroid patient that gets pregnant, we are always super worried about that fetus for that first 10 weeks or so when the baby doesn't have a thyroid, because they're living off mom's thyroid hormone. So it's incredibly important to tell all your hypothyroid young ladies that, if they're planning a pregnancy or they get pregnant and weren't planning it, to let whoever's managing that thyroid know ASAP, because we need a thyroid level right then. Because by the time the patient knows they're pregnant, they're usually a month pregnant already. And if they're hypothyroid, this is where cretinism comes from. So if that baby does not have enough thyroid in those very first few weeks, then they don't have appropriate neural development, and they can potentially have a lower IQ and other neurological issues. So it's incredibly important to keep that thyroid level perfect during pregnancy. In all pregnancies, the TSH runs a little low and the free T4 a little bit high. So usually we're increasing that dose right off the bat as soon as we know they're pregnant, depending upon what those levels look like. And if those ladies are taking this natural hormone, that T3 won't cross the placenta. So the kid is not getting enough thyroid hormones. So it's just not a good idea in the young ladies as well as the old ladies. So we just don't use it ever. Sometimes if people really feel poorly, if we really think they might need some T3, once in a great while, we can add T3, but you can use it separately. And it comes as a separate tablet. We know exactly what the dose is. Unlike the natural ones from batch to batch, they're very different. So you might have a batch has a lot of T3, the next batch has more T4 in it. And, the consistency is just not there with these animal ones because it depends upon what your pig had, So yeah, if we need to, we can add a little tiny 5 micrograms of liothyronine just as a separate tablet in addition to the T4. And then we can manipulate that and keep those levels normal. So it's all about keeping that TSH and the T4 in the normal range for people.
So I have patients who GI who have hypothyroidism, and they're also constipated, and they're also overweight. So is it ever tempting to tweak up the thyroid level a tad more to give them a little benefit about weight loss, get a little break on losing weight to help them get a jump start? Do you ever play with the thyroid that way?
We certainly do. And you know how we were talking about you can add or subtract those half tablets a week. Yeah. If you have someone that's within the normal range but say their TSH is 3.5, there's no reason you couldn't try to move that down to like 1 And,
Mhm.
maybe that extra half a tablet a week would do that for you.
Mhm.
But you don't want to make them hyperthyroid, because now we're back to the same problem like the natural hormone, where the patient ends up frequently hyperthyroid, and now you've caused more harm than good. But if you have someone that's sitting there at the free